Hello everyone, I am Dr. Yogeeta Goyal, currently working as Associate Professor in SPKM's Institute of Pharmacy, Dhule. The topic of my presentation is Ocular Drug Delivery System. Before moving forward to the topic, I here disclaim that this presentation is made for educational purpose only and not meant for any commercial interest. The information provided in this presentation is taken from my own experience and understanding and from the references quoted at the end of the presentation. Students, the learning objectives here are first to explain the intraocular barriers, which is level 2 of Bloom's taxonomy. Second, it infers about the corneal absorption, again level 2. Third, formulation of novel ophthalmic inserts, level 3. And to correlate the novel and conventional ocular drug delivery system, level 4. Intraocular barriers. Before speaking about intraocular barriers, what is human eye? Human eye is spherical in shape with the diameter of 23 mm. Amount of light that is entering the eyes is controlled by the pupil. It dilates and contracts. And how is the structure? The structure of that eyeball, it is divided into three parts: outermost, then middle, and the innermost part. In the outermost part, there is clear transparent cornea and the white opaque sclera. Middle layer contains iris, ciliary bodies, and the choroid. Inner part contains retina. So here the fluid is also divided as aqueous humor and vitreous humor. Cornea. What is cornea? It is the principal refractive element of the eyes. How can we see the cornea and the lens? These adjust its shape with the help of ciliary body. And what does it do? It focuses light on the retina. And here receptors convert it into nerve signals that pass into the brain. And so we can see. And it also has lacrimal glands. It secretes tears and washes the foreign bodies out of the eyes. So this is the basic anatomy of the eyes. Now specifically talking about ocular drug delivery system barriers, there are two types of barriers. One is static and other is dynamic. Static means stationary, fixed ones. Dynamic means it keep on changing. So static barriers consist of different segments of the eyes like cornea, sclera, retina, blood retinal barriers. And the dynamic barriers, it includes choroidal and conjunctival blood flow, lymphatic clearance, and the tear dilution. Delivery of the drugs to the targeted ocular tissue is restricted by various precorneal, dynamic, and static ocular barriers. I just stated dynamic and static. Now, what does precorneal means? Precorneal barriers means like spillage of the drug because of overflow. How? See, normal eyes without blinking, it can accommodate 30 ml. One drop is approximately 50 ml. What does this mean? More than 70% of the drug is expelled. So, overflow occurs. Next factor is dilution of drugs by tear turnover. Do you know normal human tear turnover is approximately 16% per minute, and again it is stimulated by various factors like drug, pH, tonicity. So because of dilution, again there are precorneal barrier. Then next is nasolacrimal drainage. What does it does? The drugs goes into systemic circulation, and which we are not expecting. We want drug to reach in the intraocular tissues. And again next precorneal barriers include conjunctival absorption and enzymatic metabolism also takes place. So there are number of barriers which include precorneal, dynamic, and static ocular barriers. This is the reason that delivery of the drug through the eyes is very challenging because of blinking action of the eyes, because of tears, because of these barriers, very less amount of drug is instilled in the eyes and absorption is very poor. Now, absorption. So, absorption through the eyes takes place through two methods. One is corneal absorption and the second is non-corneal absorption. Non-corneal absorption is not that significant. Why? And how, where it takes place? Non-corneal takes place through the scleral route, conjunctival route, and it is not productive as it restrains the entry of the drug into the aqueous humor. So, primary route of absorption is cornea, and this route is very challenging. This is a main barrier for the drugs. Only small lipophilic drugs cross through corneal absorption. Why it is challenging? Because cornea consists of three layers which are responsible for its poor permeability. First is superficial layer of the epithelium, which is lipophilic. Middle layer is stroma, which is hydrophilic in nature, and this is the layer which is responsible for the thickness of the cornea. Third layer is inner endothelium, consisting of single layer of trampled epithelium like cells. You can see in these three layers, upper one is lipophilic, then hydrophilic, then again lipophilic. Means it is like fat, water, fat type of layer. So this will cause obstruction for both type of drug, hydrophilic and lipophilic drug, to cross efficiently across the cornea. Again I say, drug is in the tear fluid. Two types of absorption takes place. Corneal absorption, it is less than 10% of the dose. Next is non-corneal absorption, which mostly systemic absorption takes place for more than 50% of the drug. Here the major route is conjunctiva of the eye and nose. Minor routes are lacrimal drainage system, pharynx, GI tract, skin of the cheek and eyelid, aqueous humor and inner ocular tissues. So from the corneal route, drug goes into aqueous humor and directly to the ocular tissues. But from the non-corneal route, drugs happen to go to the systemic circulation, which is not desired. So this is the mechanism of absorption of drug through the eyes. Next, we are going to talk about OccuCert. Before starting with OccuCert, let me tell you, novel ocular drug delivery system is divided into two types. One is matrix type and second is capsular type. Example of matrix type is hydrophilic soft contact lenses. Taking advanced example of capsular type, OccuCert is the best example. OccuCert is a truly continuous controlled release and zero order kinetics can be achieved by the OccuCert. They are the novel ocular delivery system which are based on the porous membrane. The first marketed OccuCert was from Elsa Corporation. It was made for pilocarpine drug for treatment of glaucoma. Why we have made this OccuCert of pilocarpine? To improve patient compliance, to reduce the side effect, to reduce intraocular barriers. So this help in better drug delivery. And the controlled layer which was available for this OccuCert, uh, because of which this controlled release could take place, was EVA, means ethylene vinyl acetate. This is the polymer used in this OccuCert. The drug is uniformly distributed in the polymer matrix, which is made up of gelatin, and again it is surrounded by titanium dioxide. Why? For visibility purpose. Two forms were available, Pilo 20 and Pilo 40. What does it indicate? Pilo 20 means pilocarpine 20 microgram per hour will be released for 7 days. Pilo 40 microgram per hour will be released for 7 days. So you can see from this diagram, inside there is drug In the polymer matrix gelatin, there is transparent rate controlling membrane of EVA. Here it's titanium dioxide ring for visibility purpose. In this way, occlusives are prepared. These are the references which I have used for this study and preparing presentation. Thank you for your patient listening. Please feel free to write here if you have any comments, post your feedback. Thank you so much.